Thank you for joining us on yet another episode of Health Diary. My name is Gladys Gashanja and we're coming to you from the Gramo Suites in Nairobi. Now, cleft lip and palate is among the most common birth defects in the world, and in Kenya actually approximately 1 out of every 700 children born has this deformity. Now, due to ignorance and or in some cases the lack of funds to do the reconstructive surgery, some people live a life of stigma and others with the complications that come with living with this deformity. Today we focus on this deformity and understand exactly what it is and the help that is needed to walk with those that have this condition. But before we get to that conversation, here now is the fact of the matter. Cleft lip and cleft palate are openings or splits in the upper lip, the roof of the mouth, palate, or both. These conditions result when facial structures that are developing in an unborn baby don't close completely. Males are more likely to have a cleft lip with or without cleft palate, whereas cleft palate without cleft lip is more common in females. Cleft lip and cleft palate are among the most common birth defects and can be corrected. Treatment is usually recommended during childhood, but the high cost keeps many out.
Mimi ni Faith Kiloko Kitonyi. Mtoto anaitwa Phyllis Mbula Mtuko. Ako na miaka 5. Safari yangu ya ujauzito ilikuwa mzuri. Nikangoja nipate mtoto kama mtu mwingine, nikampata. Vile nilimpata alikuwa na hiyo cleft na palate. Nilishtuka sana. Juu sikuwa nimewahi ona mtoto mwingine anafanana hivyo ama mtu mwingine anafanana hivyo. Huyo ndiye alikuwa wa kwanza. Sana sana mimi nilikuwa namficha. Nilikuwa naogopa. Sasa kama saa zile nampeleka clinic namfunika sana juu unajua watu wanamwangalia sana, wanaona ako tofauti kuliko wale wengine. Akunyonya, nilikuwa tu namfeed tu na maziwa, namfeed tu na spoon. Sasa daktari mwenye alikuwa na ndio akaniambia lakini huwa inafanywa nini? Huwa inafanya repair. Sasa sikuwa najua mahali naweza enda afanyiwe. Ndio nikaambiwa cure. Nikampeleka. After amefanyiwa sasa hiyo ya ndani palate, hakuwa anaweza kuongea. Akiwa na kama alikuwa na 3 to 4 years. Hakuwa anaongea kabisa. Sasa sisi tukaanza kushindwa, sasa tutafanya nini? Sasa hatukuwa tunamuongelesha. Tulikuwa tu tunanyamaza tu. Wakasema kuna watu wa speech therapy watakuja. Kwa hivyo kama tunaweza penda tuende. Yaani kutoka hapo sasa kuongea, sasa akaanza tu kuongea tu. At least akiongea unasikia ile kitu anasema. Mtu ajipe moyo, ajikaze. Sababu kama mimi nilijikaza na nikatoboa na Phyllis, sasa hii hata akiongea unamsikia.
Now, some of us, if not all of us, has either seen somebody or knows somebody personally who has a cleft lip or palate. Now, the question begs, do you know what that is and how did you treat these people? We have that conversation on cleft lip and palate on today's episode. To help us do so, we have Beth Nduta, who is a caregiver to Andrew Njuguna Ramadan, and Dr. Thomas Sundwa, who is a maxillofacial surgeon. Thank you for joining me. Now, I'll start with you, Daktari. Cleft lip and cleft palate are as a result of facial structures developing in an unborn baby that don't close completely. What normally causes that?
There are genetic factors, which means those come from the genes, which come from inheritance, and there are environmental factors. An example of an environmental factor is drugs. So if an expectant mother uses certain drugs in the first trimester, and those drugs have been known to cause cleft lip and palate, so they may cause cleft lip and palate.
And what drugs are we talking about?
Some of the drugs are ones that are used to treat epilepsy, like phenytoin, but also drugs like the ones used in substance abuse, alcohol, especially during the periconceptional period, smoking. The biggest among the environmental factors is the lack of folic acid, a lack of iron, a lack of other essential vitamins have been associated with the cleft lip and palate.
Now, before you get into the genetic factors, let me ask Beth at this point. You have a son who had a cleft lip and a cleft palate. Okay, and he was born with it, definitely, that's when it's diagnosed. Do you have this in your family?
No.
So he was the first one?
Yeah.
Okay.
Being the third born.
And he's the third born?
Yes.
It is not only the genes that are able to cause the clefting. It is a balance between the genes and environment. So somebody may have a gene that can cause, but that person has had very good nutrition, so they are not exposed so much. They've had folic acid and iron supplementation during pregnancy. And so that kind of helps to give a check. And so you may not get clefting.
Okay. Now back to you, Beth. Tell me your experience and what you thought when you saw him.
First, I was depressed. I never thought he was my child. Niliona kama nilichinjiwa mtoto nikapewa mwingine. So the Pumwan nurses had to cancel me first. Then they brought the baby. Halafu nikawambia huyu si wangu. Mi simtaki. So it had to take time 2 to 3 days. They are doing counseling so that I accept the baby. Then the worst thing is when I went home. You have accepted him now, he's yours. Sasa unaenda nyumbani. Bwana ni yeye sasa. Amekuinukia ile mbaya. Ilisha point akaniambia tupatie huyu mtoto sumu tumuue. Akaniambia unajua kule ulimtoa? You know what you did? Na ile ulikuwa unafanya ni imekurudia. Sasa hii ni matunda ya ile maovu yote ulikuwa umepanga kunifanyia. Sasa unaona? Bado uja accept mtoto ni wako, tena umeenda ule una accept atakuhold na comfort ndiye anakuambia jua vile utafanya.
I mean, she just speaks of her experience, but this is just a drop in the ocean for many others who've gone through even worse. Yeah. And I was reading up also, there is a chance a child could have a cleft lip or palate if the mother is diabetic. Is this the case?
When a mother has diabetes, they normally have a high chance of having a child who is born overweight and with certain malformations, and diabetes could be one of them. Obesity would predispose to diabetes, and obesity can easily cause gestational diabetes and probably predispose the mother in that way. And remember, cleft lip and palate is the commonest head and neck malformation. And when you look at the body as a whole, it normally stands between number 1 and 5 many times amongst the common malformation.
When you went to the doctors, what did they tell you could have been the cause?
They didn't establish the cause.
They did not?
Yeah.
It is difficult when a patient comes to know exactly. But those linked to the genes, some of them are very specific. For instance, there are certain clefting that come with other features. One of the forms of clefts comes with pits on the lower lip. You see small holes on the lower lips. And we call that Van der Waal. So if you see a Van der Waal, you would know that it's strongly genetic. You would see a mother with it. You would see the child with it, and you know that runs strongly on the gene. And there's a 50% chance for the children. So if you have 4 children, there's a likelihood 2 can be affected. It's a dominant gene. So that would be easy for you to work out the cause.
Now, I know the complications that comes with clefting. How are you being able to breastfeed him, if at all?
Hakunyonya. It's not breastfeeding. You are doing bottle feeding. Unaweka maziwa kwa chupa unampatia.
But even that one, he needs to suckle, right? Was he being able to?
You just straight him. Then you pour it.
You drip it into his mouth.
So when he's seated up late, everything's out. So you have to keep him lying sighted, so that everything goes down.
Okay.
And that, especially that is milk country.
So you fed him on milk for how long?
For about 3 months.
Okay, and he was gaining normal weight.
Eh.
The openings also create other challenges like infections, right?
Just from the feeding, sometimes some are so severe that the children get aspiration pneumonia. Some of the food goes into the lung, and that aspiration pneumonia can cause death. So feeding can be a challenge to the extent that for some of the children born with very severe clefts, we are able to put a tube either through the nose, through the mouth, and going into the stomach to help with the feeding. And this is especially made worse when cleft is associated with a small jaw, especially the lower jaw. Then the airway becomes a challenge. Sometimes even at birth, some of the children born with clefts, because the jaw is small, are unable to breathe well. And that is why they need special care. That's why sometimes you find they are isolated so that they are given more oxygen. The airway is monitored. If it becomes difficult, the specialists are called in to manage the airway, because you may easily lose some of these children at that stage.
And we'll talk more about now the challenges the caregivers go through, which are the mothers most often than not. And even more challenges that those that live with clefting have to face. And also a question I have for you, Daktari, is how come some people stay a while before they're diagnosed to have any clefting? And he will answer that question right after this break. Welcome back. Our conversation, cleft lip and palate. You will hear the Daktari use the word clefting a lot because it actually means a split either on the lip or on the roof of the mouth. And some parts of the mouth also can be affected depending on the kind of clefting we're talking about. I'm still with Dr. Osundwa and of course Beth, who is a caregiver to Andrew, who was born with both a cleft lip and a palate. And I'll start with you, Beth. Did you deal with any infections before the surgery was done?
No. Because after visiting Daktari, after 1 week, aliniambia we have to stay in the house to minimize infections. The breathing system yake ndio awe asinfect awe na nini na throat affections ama kifua ama nini. So I had to stay in the house.
How soon after birth did you do the surgery?
We did it after 6 months. But I visited Daktari after 1 week after birth.
Generally, 3 months has been the minimum age in our setup, and that depends on our environment at which we operate the children at 3 months. However, I've been to centers where children are operated on at birth. That requires a lot of resources and it's much more expensive, requires a lot of care after. And so normally an institution develops a protocol. It develops a standard that is very closely related to what the facilities are.
Okay, now Beth, they say you can actually diagnose a cleft using ultrasound. Was this ever diagnosed when you were pregnant, or did you find out when you held the child in your hands for the first time?
I found out when I had the child.
So the doctor never mentioned anything?
It was a normal clinic.
Okay, so how is it, Daktari, that you can miss this in an ultrasound? Or is it a case of if you're not looking for it, you will not see it?
The diagnosis of cleft lip with the ultrasound is later. It's in the later stages of pregnancy. And it would require one to look out for it if there's a high index of suspicion. And that only applies to the lip. The palate is even more difficult to diagnose with ultrasound. Sometimes you may have cases of palate that are isolated. You may have a cleft palate, but without a lip. So the lip is normal, the palate is affected. And some of those may present diagnostic challenges.
Now, Beth, you took your child home 6 months later. They did the reconstructive surgery, and we can see Andrew is a normal, healthy boy today. But the challenges of those around you accepting the situation did not stop at that point. Yeah? Tell us more about that.
Everybody was like, hiyo kazi siwezi, hiyo kazi siwezi, hiyo kazi ni yako. So feeding time ni yangu, kila kitu ni yangu. It was hard. And that time you need somebody to support you. So I had to bear it. Nikamfeed, nikamvumilia mpaka akapona, na tukaendelea.
And you mentioned the father did not accept him at all. Did he finally come around?
Even today.
To date.
We need not stigmatize the families that have these children born into them, because they are otherwise normal children and have probably just been affected on that part of the body because of what we have said. And more so the mothers. We were just talking about a mother I was telling you has tried committing suicide twice. Total lack of social support because everybody withdraws. I think we have to change. Counseling can begin at the ultrasound level. When the diagnosis is made, the mother then can be prepared on what to expect and so on. We as a society, we need to embrace these children. We need to embrace the mothers. We need to embrace the families. And as you can see, Rama, it's just like anybody else.
True.
Yeah.
How many surgeries have you done so far with Rama?
3.
3. Okay, and with each he got better and better?
Yes.
At what point did he become independent, especially when it comes to the feeding?
After the second surgery.
Okay. All right, Daktari, does it depend on the severity of the cleft as to how many procedures you can do?
The cleft type determines the type of surgery one would do and the number of surgeries one would do. Essentially, for the cleft lip alone, we have said 3 months is optimum to operate on these children. Sometimes you may have the child born with a cleft palate also, and we tend to operate on the cleft palate from 9 months onwards. From 9 months to 1.5 years. We don't want to pass 1.5 years because at that time the child is beginning to talk. So we want to operate on the palate before speech development to allow the whole process to work in tandem. And then after that, they normally require dental treatment, they require orthodontic treatment to do alignment of the teeth. And as you are going, you're also following them up with how they're integrating into the society. Because after repairing the palate, you want to find out speech and communication skills and how they're integrating.
How have you been able to fund the surgeries that Rama needs?
Niliwekwa under smell train, which is free. They offered the operation free. Yes.
So they've catered for all the surgeries. Okay, now, Daktari, we know most people do not get the help they need because they cannot raise the funds that are needed to do the reconstructive surgery. So how do people know there's even this kind of help out there for them?
It is the duty of the primary health worker to direct patients to these centers. Gertrude's Children's Hospital is one of the centers that I've been involved with for quite a while now. And every week we operate on children with these facial deformities, cleft lip and palate. Everything with regard to cleft lip and palate treatment is absolutely free. I run my clinic on Thursday, so anybody can walk with a child in that clinic with a cleft lip and palate, and we'll see them then, make an initial diagnosis, and sit down and draw a plan with them.
What would you like to tell society to understand and the kind of support they should give those that are caregivers and those living with this condition?
First, ningependa kuambia watu, these children need a lot of love and caring. And lazima wakubali kama watoto wale wengine. We go through a lot, silent. But if you go deep in uongee na hawa mama, utasikia wale watu wamepitia. Na wengi wamepitishwa na familia zao, wengine ni mabwana zao. Sasa ni lazima watu wa support.
What can the country at large do to ensure that the help needed gets to everyone?
Policy level, there are certain things that have been done that have helped certain countries. For instance, in the US, they decided to fortify the cereals with folic acid. And a study was done within the region that fortification took place, and they found the incidence of clefting went down. So we can purposely, as a country, influence the fortification of our cereals, have folic acid put in the cereals that are going to make bread and so on. We need to improve on primary health care, because many times what happens is that some of these children are locked, and by the time they come to us, they are probably 10 years and the palate hasn't been repaired. So even if you repair, speech is a problem. And so we need to be open about this. We need somebody at the village who will sensitize and be in touch with this child and make sure that they've been guided to the appropriate institution.
Very well said. That has been Dr. Tom Osundo. He's actually a maxillofacial surgeon, and Beth, who is a caregiver to Andrew Rama, who is definitely healthy and thriving after a couple of, how many surgeries again? 3 surgeries since he was born. And this is just to confirm the fact that those born with this condition can live a fully fledged life if they're given the right support. And as the mother said, a lot more support needs to go to the caregivers and just get the right support system health-wise for those that are living with this condition. Thank you for joining me on this episode, and it's now time for the health tip.
It's very important to open your eyes in the water. Open your eyes, make sure you see where you're going. It helps you see if there's somebody in front of you. It also helps you see that you're swimming straight. You don't want to start at one corner of the swimming pool and then you end up getting out on the other corner. So open your eyes, it's important to see where you're going. It also helps you to see if you're moving, so that if you need to correct something about your stroke, you can correct it. But please don't close your eyes. We don't drive when we are closing our eyes. We don't write when we are closing our eyes. We don't exercise when our eyes are closed. So the only time you need to close your eyes is when you're sleeping.
The conversation has been on cleft lip and palate. Dr. Tom Osundo will be answering all those questions coming through to us on our social media handles. Thank you for joining us. My name is Gladys Gashanja, and we've been coming to you from the Gramo Suites here in Nairobi. Until next time, see you.